Lymphedema is a chronic and debilitating condition due to the mechanical insufficiency of the lymphatic system, which over time causes abnormal accumulation of protein-rich fluid in the interstitium. This triggers a cascade of adverse consequences such as fat deposition and fibrosis, and as that condition gets worse, the patient will experience heaviness of the extremities, itchiness, and recurrent skin infections that eventually will result in a significant physical and psychological morbidity, causing anxiety, depression, and social avoidance, and overall a decreased quality of life. Hi, my name is Oscar Manrique. I'm a board-certified plastic surgeon by the American Board of Plastic Surgery and a fellow of the American College of Surgeons. I would like today to briefly describe our paper titled Overview of Lymphedema for Physicians and Other Clinicians, a review of fundamental concepts. Overall, lymphedema is classified as primary and secondary. Primary occurs when there's an innate dysfunction of the lymphatic system. And on the other hand, secondary lymphedema is a more prevalent disease that develops when there's intact lymphatics that sustain a iatrogenic, infectious, or traumatic damage. Still, filarial infections is the most common cause worldwide, especially in countries with a developed economy. However, in countries with a developed economy, the lymphatic resection and radiation due to cancer control is the most common cause. Having this as background, the goal of our paper is to raise awareness of this serious condition and describe from A to Z the most current medical and surgical treatment options for patients with lymphedema. Overall, lymphedema affects nearly 250 million people worldwide. Globally, secondary lymphedema still remains far more prevalent than primary, and despite mass drug delivery programs, there's roughly 68 million cases of lymphatic filariasis, including 17 million cases of filarial lymphedema. In addition, the incidence of lymphedema following the treatment of lymph node positive melanoma and breast cancer still remains high. Currently, there are three trends that are dynamically reshaping the epidemiology of patients with lymphedema. First, the mass drug delivery program coordinated by the World Health Organization, which is attempting to eradicate filariasis around the world. Second, the radical shift that has occurred over recent decades in the adoption of lymph node sparing cancer operations. And third, the pandemic obesity. As we know, the National Lymphedema Network has done a great job in terms of trying to find out which patients are at risk and what should they do. So patients at risk are qualified or are those who had any lymph node removed or radiation therapy during the treatment of cancer, and those individuals who have family members with hereditary lymphedema could also be at risk. They recommend that those patients who are high risk should have regular follow-ups with their primary care to look at limb measurements, assessment of post-treatment physical impairment, functional status, and a subjective self-report of symptoms. And this is important because usually we will see that these symptoms are insidious, which it means they start around 6 months to 3 years from the time of the original operation. In addition, body weight should be maintained within normal limits, and any increase should prompt a patient to seek professional help to lose that weight. Now, how do we evaluate and follow up patients with lymphedema? With the onset of lymphedema, as I already explained, is very insidious. The key is to have a baseline of measurements of the affected limb and compare it with the non-affected limb, which is critical in order to have this baseline and to monitor the progression of the disease as the time goes on. In addition to a physical exam, there are other diagnostic tests that are important to use, which at the same time are, in addition of the physical examination, important that they're not invasive, cost-effective, and are a reliable physical exam with minimal rate of variability. What are those non-invasive measurements? So overall, in clinic, what we do is to look at the limb volume or circumference that are used to calculate the difference between the affected and non-affected limb. The most common of doing this is by measuring tape. However, it's important that it's done by the same personnel that are equipped and knowledgeable about lymphedema. So with that, the variability of the results is not going to be significant. In terms of the imaging measurements, There are several techniques that are used. So far, the gold standard is still lymphoscintigraphy. However, depending on the practice, it's very important to have the same type of imaging measurements in order not to change the diagnostic patterns. The important thing of a good imaging measurement is that it's going to help us to see what's the baseline of the in the severity of the disease, will help us stage, and also follow up after treatment. How do we manage these patients when they present with lymphedema? The current international standard for initial lymphedema treatment is referred as the complete decongestive therapy, or CDT. It's very important that the patients follow out these strict guidelines and protocols, as this will be or result or achieve a good clinical outcome. The principles of surgical management of lymphedema are usually to prevent infections, to help decrease the volume of the limb, in order to improve the lymphatic flow, and with that obtain a good surgical outcome. With the advances in the understanding of the lymphatic system and new technology and improved skill sets, this has resulted in an increased number of surgical options. The goals are to improve, as I mentioned, the lymph function and cosmesis, reduce the episodes of infection, and prevent the progression of the disease. Patients usually at earlier stages are offered surgery if they have been symptomatic for close to a year and have failed to improve with at least 6 months of physical therapy. In more severe stages, patients are offered surgery if they've been symptomatic for at least a year. Broadly, the two main types of surgical intervention are divided in physiological and excisional or reductive. Physiological means that using microsurgical and supramicrosurgical techniques, the goal is to restore the lymphatic flow by either bypassing the lymphatic system or transplanting lymph nodes from other parts of the body. Now, for the excisional procedures, that means that there's going to be a debulking of the limb, which it can consist with what is historically known as Charles or modified Charles. And currently, there are other techniques such as liposuction or limb reduction with preservation of perforations, which gives also a very good and aesthetic outcome. Currently, and as the practice has advanced, we now try to do what it's called preventive procedures. What does that mean? That at the time of the original cancer operation, if there's any obvious lymphatic leakage, we've been trying to connect some of these lymphatic channels to veins that are in the vicinity of the resection. This is called the lympha procedure, which is called the lymphatic microsurgical preventive healing approach. Still, studies are in progress in order to look for the results of these techniques, but so far the results have been very promising. And as I explained, in cases in which the stages are a little bit more advanced, excisional procedures are the way to go. So in summary, the early detection and education are key in order to prevent the progression of the disease. There are current very good surgical techniques and approaches in order to help patients to decrease the progression of the problem. And still currently, physical therapy is the gold standard of treatment. However, we hope that with research and surgical intervention for the future, that the outcomes of lymphedema surgery will continue to improve. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.